So good morning and welcome to today's webinar on the treatment management and research innovations in adult acute lymphoblastic leukemia, or otherwise known as ALL. My name is Linda Saunders. I'm representing the Leukaemia Foundation and I will be chairing today's webinar along with my esteemed colleague Jane Anderson, who's with us from Hobart. We'd like to commence today with an acknowledgement to country. We'd like to acknowledge the traditional owners of country throughout Australia. The land I'm currently standing on, the Wathaurong people of Geelong, and the lands that you're standing on, and recognise their continuing connection to land, sea and community. We pay our respects to their elders past, present and emerging. We'd also like to thank Amgen for supporting this webinar today. So today we are shining a light on ALL. We have three wonderful guest speakers, all looking at ALL from a different angle. We have Mr. Mark Reed from Hobart, who is sharing his lived experience of ALL. We have Dr. Matthew Greenwood from Sydney, who's providing a clinical perspective, so looking at the diagnostics and the treatment management of ALL. And thirdly, we have Professor Deborah White from Adelaide, who'll be looking at ALL from a research perspective, in particular focusing in on precision medicine in ALL. So on that note, I will hand over to Jane to introduce our first speaker.
Good morning, everyone, and welcome to this wonderful ALL seminar that we've put together for you. I'd like to introduce Mark Reed, who is a patient from Hobart who was diagnosed in October 2019. He then had to endure treatment and travel to Melbourne through COVID in 2020. And we welcome Mark to share his story and experience with us now. Thank you.
I'd just like to start with telling everyone a little bit about my story and my journey and being diagnosed with ALL, and hopefully just give some advice to people that are dealing with it now and everyone that's listening. So it started from me, as Jane said, back in 2019. The 3rd of October, a day I remember very clearly and never will forget. Previous to my diagnosis, I have a young family. I have two boys, 15 and 14. At the moment, we enjoyed mountain biking, out on a boat, wakeboarding through the summer, anything that involves AFL footy. We played touch footy. Very active lifestyle. I'm a project manager as my profession, so I'm used to solving problems, and that's pretty much what I do day to day. I started getting fatigued in my legs around mountain biking and other physical activity. I went to a doctor and had a blood test at 10 a.m. on a Wednesday. At 8 p.m. that night, that doctor contacted me and said, "You need to go see this lady in the morning. Get straight in there." So that's what we did. We searched up that lady's name that night, and that lady was Dr. Rosie Harrop, who's the head of oncology here in Hobart and Tasmania, I believe. So very restless night. At 8:30 the next morning, we were sitting in Rosie's office, and she told myself and my wife that straight out that we have ALL, that I have ALL leukemia, and this came as a massive shock. It was just pretty much devastation straight up. So the diagnosis was really difficult to take to start with, being so active, and like I said, being able to sort most problems. It became very evident to me immediately that this wasn't a problem that I would be able to sort out, and it was going to be a long road. So within half an hour, I was having a bone marrow biopsy just to measure the amount of leukemia that was in my body. So if you can imagine, and being told half hour later you're having a bone marrow biopsy, which is, it was pretty full on. So the hardest thing for me and my family was, like I said, the initial shock of the diagnosis, which come with a lot of uncertainty, and the uncertainty was, the journey that I was about to undertake, and obviously that uncertainty revolved around whether I was actually going to be okay and be able to get through it. It was a big thing for me. As it went on, I sort of thought, if the worst was to happen, well, that would happen to me, and I was more worried about my wife and two boys and how they were going to react. So to me, that was a massive thing as to the impact it was having on the rest of my family. So once we had that sink in, we were straight home to tell our boys, which was a pretty horrible sort of thing to have to tell our boys. And then basically it was pack my bags and back into hospital. I had one night at home, and then I was back into hospital for treatment. Chemo started straight away, and there were, once again, that word uncertainty. There was a lot of uncertainty about the chemo treatment, exactly what it was going to do to my body. There's a lot of advice offered from the Leukaemia Foundation, which I'm very grateful and would advise anyone to take up. But I would also advise people to find a support person, if possible, that is going to be best for you, whether that's your immediate partner or someone else. But that's a vital part of getting through this journey, is being able to find that support person and someone to help you, because pretty soon with my treatment, and I'm not saying it's like this for everyone goes on an individual journey, but pretty soon my thinking capacity was reduced. I was very fatigued due to chemo treatment, which it starts out pretty heavy and it just gets heavier. So being able to manage medication and just day-to-day life becomes reduced pretty quickly, and having that support person with you to be able to manage those things is invaluable. So you basically, I had to give up work straight away. I had visions of being able to work here and there. I had visions of being able to retain my normal life here and there, but they were pretty quickly taken away from me, and I quickly realised that I was not capable of working throughout this, especially due to the extensive chemo treatment, and that I would need support in just general day-to-day stuff. So the advice I received from Jane here was awesome, and one of the things that Jane said to me was, you really need to concentrate on yourself and your exercise and keep that up, even if it's just a simple walk around the hospital ward, or once you're not in hospital, just getting out and going for a walk along the beach or wherever it may be available to you was very beneficial. So I tried to keep up that as much as possible, which was difficult at times, but there's a definite advantage in being able to keep exercising. The other thing that it took me a little while to learn, but basically once I got my head around the positive thinking side of things, and I know that is the main theme that people will say to you, and my thinking was, we'll go through this and what will be. But once I changed that thinking to a positive mindset, my results improved dramatically, and I started to come through the whole process. So as mentioned, once my treatment was done in Hobart, which was over a 3-month period. I had a month off to prepare myself for a bone marrow transplant, which I went to Melbourne and had done. And I thought I was prepared for that, but yeah, it's a very difficult process as well, which just basically was harder than anything I've ever had to do, and hopefully anything I ever have to do. So the key challenges were just maintaining my mental state throughout the whole process. That was a huge challenge for me. I thought I'd be on top of it. I've never had any mental health issues previous to this, but I definitely had mental health issues throughout it, which I was able to manage and get on top of now. I think that with me, it come with turning my thinking into a more positive mindset. Living with it, I live with it now. My life's back to normal, well, as close to normal as can be. It's getting back there. That was something I craved while I was unwell, was just to get the normal stuff back, just to go to work, get up, I was in the kitchen doing the dishes last night. I thought, how good's this? So those normal things are just, when they're taken away, they're the first thing you want back. And it is achievable to get them back. You just need to really take each day as it is, each diagnosis as it is, try and work through it, try and keep your body in the best possible condition that you can, and your mental health is a massive part of that. So those are really the only things you can do to, for me, that can help you get through this process, is just trying to focus all your energy onto yourself, and having that support network as well is vital, because there's times when it's difficult to see tomorrow, and it's difficult to see a way out. But with that support person helping you in this space, it can just be pretty much invaluable. I live with it every day now. I'm out to 6 weeks on a blood test, where at one stage it was 3 times a week. So basically living with it is, it's just something you need to get your head around and realise that this is the pathway now. So that has challenges within itself, but once you work through it and your life starts to turn back to a little bit of normality, and things are a little bit normal in your life, well, then I think your mental space comes along with it, and definitely helps you in that area. So the key messages I would have is definitely stay positive, really try and look after yourself, focus all your time and energy on yourself. It's okay to be not mentally okay, that's fine. Talk to someone about it, get some help, tell your closest person or whoever that may be what issues you're experiencing. They can help you. My wife was awesome. She helped me through so many dark times, and just let me know that there will be tomorrow, and things will get better. Hopefully things will get better. So they are the key messages I'd like to put out to everyone. And I just remember how worried, how scared and how frightened I was when I was initially diagnosed, and that's the reason why today I'd like to be able to give back to anyone that's listening, and hopefully they can get something out of it. So basically look after yourself and really work hard on your mental state and what the advantages that can bring. So I'm also happy if anyone really needs someone to talk to. I'm happy to explore that option through the Leukaemia Foundation. So thanks for your time today, and I hope and wish everyone that's listening well. And I understand how daunting and just how scary this experience is, and hopefully me talking to you about it today can help you just a little bit. Thank you.
Thanks so much, Mark, for your really candid and revealing and honest sharing of your experience, which was actually really quite recent, and complicated by the events of COVID last year as well. So thank you for setting the scene really for today's webinar. So on that note, I'd like to introduce our second speaker, Dr. Matthew Greenwood. Dr. Matthew Greenwood is Director of Stem Cell Transplantation at the Royal North Shore Hospital in Sydney. After completing haematology training in Sydney, Dr. Greenwood completed a Leukemia Transplant Fellowship at the British Columbia Cancer Agency and a Canadian Stem Cell Network Fellowship at the Terry Fox Lab in Vancouver. He's currently co-chair of the Acute Leukaemia Working Party of the Australasian Leukemia and Lymphoma Group, and a lead investigator on the ALLG, ALL06 and ALL09 studies in AYA ALL. Quite a mouthful there. Thank you, Matt. I'll hand over to you.
So here are my disclosures before we get started. Sorry, there's a bit of a lag. So briefly, I just wanted to mention the different types of leukemia that people may develop in adulthood. And in general, we divide them into acute leukemias and chronic leukemias. Of the two acute leukemias, there's acute myeloid leukemia, which is the most common in adults, and then acute lymphocytic or lymphoblastic leukemia, which is what we'll be talking about mainly today. These are what these cells look like under the microscope. So they're big, nasty cells, which we call blasts. And really, under a microscope, it can be quite challenging to tell the difference between AML, acute myeloid leukemia, and ALL, or lymphoblastic leukemia. And so often we need a number of ancillary tests to be able to differentiate between the two, which is important because the treatment is really very, very different. And what is leukemia? Well, to have an understanding about what leukemia is, you really need an understanding about how blood is produced. Blood is produced mainly in the bone marrow, and all blood arises from a single cell called a stem cell, of which there's a small number in humans. Stem cells divide into myeloid cells and lymphoid cells, and myeloid cells go on to develop all the white cells that we see in the peripheral blood, along with red cells and platelets. And when you develop AML, there is a problem in the step where immature white cells, immature myeloid cells go to develop into mature cells, typically because they accumulate a large number of different genetic abnormalities. That's AML. In the lymphoid lineage, a lymphoid stem cell divides into a lymphoblast, and that goes on to develop other types of white cells in the blood called lymphocytes, which are typically B or T. And unfortunately, somewhere along the way in ALL, there again is a number of genetic abnormalities, which Professor White is going to discuss in a bit more detail after my talk. A number of genetic abnormalities that accumulate within a lymphoblast, which stops develops as a result. So what are the signs and symptoms of ALL? Well, as Mark alluded to, they can be fairly non-specific, and typically it's very hard to make a diagnosis without having a blood count performed. Usually a blood count's performed by a GP under these circumstances. But some of the more common signs and symptoms of ALL, people might present with a weakness and fatigue, typically from anemia, night sweats, which just drenching night sweats that really don't resolve, go on night after, weight loss and a loss of appetite, sometimes pains in bones and joints, infective symptoms, fevers, enlarged lymph nodes. Sometimes because the liver and spleen are enlarged, people develop swelling in their abdomen. Bleeding and bruising can be quite common because the platelet count falls, and that predisposes people to bleeding. And patients might note or family say they look quite pale because they're very anemic. But as you can see, those symptoms are really very non-specific. So typically what would happen is that patients who are unwell will present to their GP and they'll have a blood count performed. And the blood count will be run through a machine to have a look and see what sorts of cells are present in the full blood count. And often the machine can detect a large number of very abnormal cells, which means that a blood film will be made. Of these very abnormal, very large cells present in the blood film. Those abnormally large and unusual cells are called blasts. And then typically we run those cells through a machine called a flow cytometer. And on this flow cytometer plot, you can see here that these cells express CD34, so up here, and CD19 over here, which is these unusual cells in here. And that would typically mean that those cells, and again, you can see that those cells can be seen here in this flow plot. Once a scientist or a hematologist sees these results, they'll ask the patient to come in, usually to the emergency department, and then to confirm the diagnosis, we do a bone marrow biopsy to have a look and see what is going on inside the bone marrow. And in ALL, we will typically see very large numbers of these types of cells that we can see in the blood, also in the bone marrow. Often 90% or more of the bone marrow becomes, looks very similar to these sorts of cells in patients with acute lymphoblastic leukemia. Because ALL can present with other presentations, including involvement in the brain or spinal cord. Typically, once a diagnosis is made, we have to do what's called a lumbar puncture, so we can have a look and see if there is leukemia in the brain or spinal cord. And we often also do CT scanning because sometimes the lymphoid tissue in the body, such as lymph nodes, to be expanded in ALL, and a CT scan will show us that much more clearly than a chest X-ray or other types of X-rays. And on this CT scan, you can see here that there's a large mass just at the front of the chest there, which is typically an enlarged thymus. So all those tests will be done once a patient has been diagnosed with ALL. So this is really just to reiterate what tests we do. About the sort of testing that she does in Adelaide. But typically what we do are tests where we look at the bone marrow under the microscope, and that's called morphology. We basically look to see what the leukemia looks like. We also run the bone marrow through a machine called a flow cytometer, and that tells us what sort of leukemia this may be. In the case of a B cell leukemia, it will express these sorts of proteins, 19, 20, 22, or a T cell leukemia that expresses other types of proteins like CD3 and CD7. In addition, we send the bone marrow off for chromosomal analysis to have a look and see what sort of chromosomes might be present in the leukemia cells. And critically in ALL, we want to know whether or not, in this case, the leukemia cells express what's called a Philadelphia chromosome. Is this Philadelphia positive? Or is the ALL Philadelphia negative, which is the more common type? And we ask that question because we know there are certain drugs called tyrosine kinase inhibitors that will be more helpful if the patient is Philadelphia positive. In addition, there are some certain high-risk markers that we look for when we look at chromosomes. And we know that in those high-risk patients who express those chromosomes, doing a transplant from somebody else, using somebody else's stem cells, in their first remission may well improve their outcome. So we look for other types of high-risk chromosomal markers, and the most common one that we look for in adults is something called translocation 411. Importantly, we also send markers off for what's called minimal residual disease testing, and I'll come to that a bit later. We also, in certain situations, send the leukemia off for much more detailed molecular analysis, often called sequencing. That's much more common on a clinical trial. In Australia, much of that analysis is done by Professor White. We look to see whether or not this might be Philadelphia-like disease, which is much more common in the sort of patients that I treat between the ages of 15 and 39 that might have some prognostic significance. And we also look for other mutations that might be targetable by drugs that we might be able to access, not routinely, but we might be able to access for certain patients who have these mutations. And that might be helpful if the patient does complete remission or an MRD remission at certain time points during their protocol. And in addition, we often ask the patient whether we can store their bone marrow for future analysis. And currently, the most common registry where their bone marrow would be stored is the National Blood Cancer Registry, which is run by the Australasian Leukemia and Lymphoma Group. So when we look at the chemotherapy that's given now to particularly young adults and adolescents with Philadelphia negative adult ALL, we are typically using protocols that have now been previously developed in children, and we know that if we can use those protocols, there is often a much better outcome for patients between the ages of 15 and 39 than if we used adult protocols that are more commonly used now in older adults. And what is it about the protocols that we use based on children's leukemia that are helpful when we're treating younger adults? And there are some very common themes about these protocols, and in general, they're probably best referred to as LOTSA protocols because there's lots of everything in. They're mainly BFM based, and that's the Berlin Frankfurt Munster clinical trial group. And that means they follow a certain pattern, and the pattern is induction chemotherapy followed by consolidation chemotherapy that often involves treatment to eradicate leukemia from the brain and spinal cord. And then another round of reinduction to consolidate and improve the outcome for patients with ALL. And typically there's very prolonged maintenance, usually over a minimum. They involve multiple chemotherapy agents, and they all target different aspects of the cell cycle to try and maximize leukemia cell kill. There are lots of drugs involved in CNS prophylaxis to try and minimize the risk that the leukemia will come back in the brain and spinal cord. There's also lots of asparaginase, which is a drug which is very effective in ALL, but also can be quite toxic, particularly in adults. And there's also lots of maintenance therapy. So the minimum amount of maintenance that is used in these protocols typically will complete the treatment course over a 2-year period, but sometimes the maintenance itself can go for up to 2 years. Typically, the treatments are what's called less myelotoxic, so they should reduce the neutrophil count less than the lymphocyte count, and I'm not sure that really holds true in adults. I think most adults tolerate this less well than children. And there is lots of cumulative doses of chemotherapy. So the doses of chemotherapy that are given over a 9 to 10 month period are much, much higher than would be given in other protocols in older adults. And the sort of protocols that are used in younger patients, ALL6, which is one of the clinical trials that's now completed in Australia, a US protocol called CALGB 10403, a French protocol called FRALI, the German protocol BFM 2000, and currently, if the trial is open at the site where you're being treated and you otherwise meet criteria, then the ALL9 clinical trial. But all of these pediatric protocols share this very similar theme of lots of chemotherapy given over a very prolonged time course. In older adults, we know that these sorts of protocols, most circumstances, we have to be much more circumspect about the type of chemotherapy that we can use, the doses of the chemotherapies that are used, and how frequently they're given. In younger adults, a French study called GRAL is the type of protocol that might be used, or a US protocol called Hyper-CVAD. There's also another US protocol called CALGB 8811 that's designed for older patients. Or depending on the centre that you're being treated at, also a UK study, or a sort of combined UK and US study called UK ALL 12. And the themes that are more common to these older adult protocols is less chemotherapy given less frequently. Most of these do not involve asparaginase because asparaginase is quite toxic in older patients. And as a result, because the protocols are less intensive and less aggressive, the outcomes tend to be a little bit less good than the types of outcomes we see in younger adults. In addition to that, older adults tend to have much higher risk ALL. And so it's more common that older adults may have their treatment consolidated by a allogeneic transplant to try and improve their outcomes. So these are the sorts of outcomes that we might expect for patients, depending on the sort of protocol that they receive. And you can see here, these are the outcomes from the CALGB study that was published in Blood 2 years ago. And CALGB 10403 was designed for patients between the ages of 15 and 39, so adolescents and young adults. And you can see that the 5-year survival is around 68%. And the event-free survival is slightly lower than that, as is the disease-free survival. The Hyper-CVAD regimen, which was published quite a number of years ago now, when it was published, it had an older age group, so the median age was 40, but they were able to treat patients up to the age of 92. And you can see that the outcome for these patients is much worse than if a more aggressive protocol is treated. But the treatment is much more tolerable. You can see in this cohort, patients up to the age of 92 were treated using this chemotherapy protocol. So it's a much more tolerable protocol. And at least a third of the patients in this cohort were over the age of 50 years. But because it's a less intensive protocol, you can see that the outcomes, the 5-year outcomes here, are only 40 to 45%. So less good outcomes than we might expect with younger adults with more aggressive treatment. When we look at patients over the age of 65, there's really no standard of care for those patients when they present with ALL, and the outcomes remain quite poor for individuals over the age of 65. At my site, we typically use a protocol called the EWAL protocol, and you can see really, even with that treatment that does include asparaginase, it's relatively aggressive for older patients. You can see the 5-year outcomes are only around 25 to 30%, so really quite poor. You can see that the older you are, and you can see here patients, it's quite small, but I think this is 85 plus years. You can see even over the age of 65 that you can stratify outcome according to 5-year blocks. So these are patients who are 65 to 69, and these are patients who are 85 plus. So the older you are, the less well you will do. And a lot of that boils down to the type of treatment that patients who are older can tolerate, which is clearly less aggressive. Sorry, there's quite a lag on these slides, unfortunately. So what is the importance of the Philadelphia chromosome? I discussed earlier that one of the characteristics of the tests that we do in bone marrow at diagnosis is to look for the presence of a Philadelphia chromosome. And the reason we do that is because we can use a type of drug called a tyrosine kinase inhibitor, and these are the drugs that we can access we can use those drugs to try and target the abnormality that occurs when a patient develops a Philadelphia positive ALL. And the protein that's developed as a result of that is something called BCR-ABL, and we can target that with these drugs. And you can see here that if we use a TKI in patients who have Philadelphia positive ALL, you can see that they will do much better, which is the top curve here, than if we don't use a TKI, which is this bottom curve here. So for patients who have a Philadelphia positive ALL, it's more common as you get older, we typically will always try to incorporate a TKI, either imatinib, dasatinib, all these other drugs here, nilotinib, together with chemotherapy to try and improve the outcome of patients who have a Philadelphia chromosome in their ALL. And typically in Australia, most of those patients will then also proceed to a bone marrow transplant to try and improve their long-term outcome. So I mentioned earlier at diagnosis, we send bone marrow off for minimal residual disease testing. And what I'd just like to discuss now is what is minimal residual disease? Minimal residual disease is where we look at the amount of leukemia present, but down to very, very, very low levels, levels that can only really be detected by molecular testing. And you can see here that when we look for the amount of ALL present in the bone marrow after we start treatment, you can see that if we look just on the basis of morphology under a microscope, we say that patients are in remission when they have less than 5% leukemia cells in their bone marrow, so 1 in 20. But that's clearly not a very good remission, and really what we want to see is as deep a remission as possible, ideally to the point where we can't detect any leukemia cells at all. And we can really only assess that by looking at this type of testing called minimal residual disease testing, or MRD. And you can see that when we use MRD, we can get down to very, very, very low levels of detection of leukemia, and under the best circumstances, maybe down to 1 in a million leukemia cells. And we can only really do that if we look for different types of minimal residual disease. And one type of test that we can do is a flow cytometry assay, where we can get down, under the best circumstances, down to maybe 1 in 1,000 or 1 in 10,000 cells. Then we can do molecular testing based on PCR, and we can often get down to 1 in 10,000 or 1 in 100,000 cells. Or sometimes using an assay called next generation sequencing, we might be even able to get down to less than 1 in a million cells. And the deeper the remission, the better the response, and the better the outcome in the longer term. So that's why we do MRD testing, because we want to see whether we can use a marker to follow, a molecular marker, to follow through the treatment course to assess how well the patient is eradicating their leukemia. There are a number of different ways of doing this. The most common, I think, in Australia is probably a PCR-based method. Most of that testing is done at the moment in Sydney at Randwick. There is also a lab in Melbourne that will also do that assay at the Austin Hospital. There are also flow cytometry based methods, and most of the flow cytometry at the moment is done in Melbourne as well. That's a harder test to standardize across sites. And at the moment, there are a number of labs in Australia looking to set up next generation sequencing testing as well. It's not really such a routine test, though it is being offered in Melbourne at the moment. So why is MRD so important? Because it really helps us predict the outcome for the patient. And these are outcomes for patients on the German multi-center studies. So these are adult patients where their MRD was assessed at around week 10 or so in their treatment course. And you can see that patients who are MRD negative, which are these, sorry about that, that are MRD negative, which in this case is called a molecular CR, will do much better than those patients who are called molecular failures, who either have high levels of residual MRD or whose MRD recurs. And really, that is a very significant predictor of outcome for patients. It predicts their survival after treatment. And so under those circumstances, MRD is really very important. The important thing also to remember about MRD, though, is that the time points that are assessed are protocol dependent. And when your MRD might be assessed is really dependent upon the sort of treatment that you are receiving. And the time points that are the most prognostic are different between different protocols. So what might we do if we find that patients aren't achieving the goals that we're looking for according to their MRD? So they're not achieving their treatment milestones. Well, these are the sorts of things that we might do based on MRD testing. So if you had evidence of low MRD at a certain time point, your treating clinicians might, this is much more common in children, much less common in adults, might consider de-escalating your therapy or not intensifying your therapy, for example. If you had an intermediate result in your MRD, then it's likely that you will just continue to have standard therapy. And some of those patients who have standard therapy will continue to do well. Other patients with intermediate results, their MRD might increase over time, and they might then have to have their treatment intensified at a subsequent point in their protocol. Other patients, for example, if they have high levels of MRD, then they might receive a much more intensive protocol to try and get their MRD lower, or they might proceed to have a transplant. And the important thing to remember about all of these treatment decisions are that they all occur in patients who, for all intents and purposes, by standard definition, look as if they are in remission. So that's the most important aspect of MRD, is that we see that patients who are in remission by all the standard criteria, we can actually monitor their MRD and try to improve their outcome by stratifying their treatment according to their MRD results at certain points in their protocol. So when is a transplant a good idea in adult ALL? And there are certain criteria that we use that have been developed over a number of different clinical trials. Patient's response, and whether or not those patients will go on and do well with standard therapy or poorly with standard therapy and should be consolidated with a bone marrow transplant. And these are some of the more common criteria that are used. So if you have a delayed remission, if your bone marrow still has evidence of disease at an early time point, they're the sort of patients who we might consider doing an allogeneic transplant on. If you have a high risk for relapse based on factors that are identified at diagnosis, such as your presenting white cell count, typically if it's over 100, if you have what's called a poor prednisone response, so your leukemia cells don't disappear from the blood after a course of prednisone for a week or so. If you're Philadelphia positive, we know even with TKI therapy, those patients have a high risk of recurrence. If you have what's called an MLL translocation, like a translocation 411, we know those patients will do poorly without a bone marrow transplant. If you also have this type of T-cell leukemia, that's a newly recognized type of T-cell leukemia called early thymic progenitor, or ETP ALL, we also know those patients will do poorly with standard therapy. And so most of these patients will be considered for bone marrow transplant, even based on their diagnostic results. If you have a poor MRD response at certain time points in your protocol, it's likely you will do better if you have a bone marrow transplant. If you're older age, I often consider doing bone marrow transplants for patients who can't tolerate a pediatric regimen. And clearly, if you have relapse disease, your outcome is much better if you have a bone marrow transplant. And why do we do bone marrow transplants? We do bone marrow transplants because of this effect here called graft versus leukemia. And that's where your donor, usually either a family member or a donor, unrelated international registry, we use their immune system when we transplant that immune system into the recipient, to recognize their tissues, including their leukemia, as being something foreign. They set up an immune response, the donor sets up an immune response against the recipient, in addition to setting up an immune response against their leukemia, and destroys their leukemia by using an immune-based therapy. It is the original immunotherapy, and it's very effective in improving outcome in patients with high-risk acute leukemia, including high-risk ALL. And we know that the effect of graft versus leukemia in ALL is increasingly well recognized, and there are increasing indications to offer an allogeneic transplant in patients' first remission. And you can see this is data from the International Bone Marrow Transplant Registry based in the US that most Australian centres contribute to. And you can see that over time, from the year 2000 to 2019, there's been really a significant increase in the number of transplants that have been performed for patients with ALL, certainly younger patients, as well as even older patients where in the past we may not have considered doing a bone marrow transplant. For children, bone marrow transplantation remains fairly stable. So there's only really the same number of patients being considered for transplant now as was even the case 20 years ago. But slowly but surely, there's an increased number of over 65-year-olds who are also being considered for transplant. So transplantation early in the disease course is an increasingly accepted option for patients with ALL. And you can see that the bulk of those transplants are really now being performed in patients' first remission, so that there's an increasing recognition that there are certain types of leukemia that should be offered a transplant early in the disease course. And in addition to that, you can see that partly the reason why there's a recognition that doing a transplant in the patient's first remission is that they will do better if they have a bone marrow transplant in their first remission, as opposed to their second remission or beyond, or if they never achieve remission. So there really can be a benefit for certain individuals in having a transplant in their first remission and not waiting for the patient to relapse if they have high-risk markers identified at diagnosis or during their treatment course. And you can also see that overall we're getting better at offering, we're getting better at doing transplants in patients with ALL, because over time there's been an increase in the survival of patients who have had a transplant for ALL, really quite a significant improvement in the 4 years from 2001 down here versus the 4 years from 2016, for which there's most recent data available. So what are some of the new agents that are available for ALL? I'll go through each of these in turn, but Inotuzumab is an antibody that's bound to a toxin that's very useful in patients who have relapsed ALL. Blinatumomab is what's called a bispecific antibody that's useful for relapsed ALL, and then Tisangelucil, which is a CAR T cell therapy, and all of these treatments are now approved in Australia for patients who have relapsed ALL. So firstly, Blinatumomab. Blinatumomab is what's called a BiTE antibody, a bispecific antibody that's directed against the CD19 protein on ALL B cells. And what it does is it uses components of a T cell engaging antibody. So it uses the patient's own T cells to try and come together with a tumor cell that expresses CD19. And it has a small linker protein here that binds these two components of the antibody, so an anti-CD3 or anti-T cell antibody together with a anti-CD19 antibody. That's infused into the patient, and what that should do is it should engage the patient's T cells to bind to tumor cells and kill them. and it's relatively effective in doing that. You can see these are the results from the Tower study using Blinatumomab in relapsed refractory disease versus standard of care therapy. And you can see that more patients achieved a complete remission in that circumstance if they received Blinatumomab. The duration of their remission was longer. The event-free survival was better at 6 months. The overall survival was also better, but the number of patients who proceeded to a transplant was around about the same. The therapy for relapsed refractory leukemia using Blinatumomab also achieved a good MRD response. So a complete MRD response was seen in around 50% of patients if it was used as the first salvage therapy, but that wasn't significantly different from patients who had a standard of care therapy. But you can see the MRD response for patients where Blinatumomab was used as the second salvage therapy or beyond was much higher. So again, almost 48%, almost 50% of patients who still achieved an MRD negative response versus those patients who received standard of care therapy in second or beyond salvage. So Blinatumomab was an excellent drug for improving outcome, but also achieving an MRD negative response that hopefully sets up the patient for improved outcomes beyond transplant. But you can also see that over time, the outcomes using Blinatumomab remain fairly poor for patients with relapsed refractory disease. So we really don't want patients to relapse. We want them to be cured in their first remission, and we try to avoid relapse if at all possible, which is why we try to intensify therapy when the patients first present, rather than intensifying therapy on relapse. So studies have also been done when looking at patients who just have MRD positive ALL as opposed to frank relapse, where we can see blasts in their bone marrow. And you can see again that for patients who received Blinatumomab with MRD positive disease, the outcomes are really very good. Those patients eradicated their MRD in almost 80% of occasions. In months was very good. It was over 50%, and the median survival for patients was 3 years. For patients who had an MRD response to Blinatumomab, their outcomes were superior than if they didn't have an MRD response. So now we can use Blinatumomab in patients who still have MRD positive disease, and that is approved in Australia for that indication. Blinatumomab has also been looked at in relapsed refractory Philadelphia positive ALL. And this is really a very poor subgroup of patients. They tend to do very poorly with standard therapy. These are relatively small groups of individuals, so this is a small study. But again, with Blinatumomab, there was a reasonable complete remission rate. More than a third of patients achieved a complete remission. And of those patients, almost 90% achieved a complete MRD response. So again, that sets the patient up for a good outcome if they're proceeding to transplant. But again, we really don't want patients to relapse with ALL. You can see that the median relapse-free and overall survival in this patient group is relatively poor. So even though these patients have an option for salvage using Blinatumomab, we really don't want patients to relapse if we can avoid it, because the outcomes overall remain fairly poor. So another therapy that can be used for patients who have relapsed refractory disease in Australia is inotuzumab. It's anti-CD22. It's an antibody that's bound to a toxin called calicheamicin. And that antibody then binds to CD22 positive B cells and results in their death when the calicheamicin is integrated into the cell machinery. And that study has also been looked at in a randomized study against otherwise standard chemotherapy. And you can see the CR rate is really very good for inotuzumab, 80% versus standard of care therapy, 30%. The MRD negativity rate is really very good as well, very similar to blinatumomab, 78%. Duration of response, though, is relatively short compared to standard of care, and the progression-free survival, again, remains relatively short, as does the overall survival. And so while inotuzumab is an excellent drug for achieving remission in patients who have relapsed refractory disease, most of us think about it as a bridge to transplantation, as a way to get the patient to a transplant. One of the concerns about inotuzumab is the rate of what's called veno-occlusive disease, which can be very problematic following a transplant. And so there are ways and means that we try to minimize the risk of developing VOD by delaying the last chemotherapy before transplant, having a reasonable interval between the last dose of inotuzumab and proceeding to transplant if that's required. And you can see that inotuzumab has also been looked at in Philadelphia positive disease, and overall, again, the outcomes are better than standard of care therapy in this context. But again, the event-free and overall survivals are relatively short, but it does set up the patient, hopefully, to maximally benefit from a transplant in that sort of scenario. Again, the MRD negativity rate using inotuzumab in Philadelphia positive disease is really quite high. So let's come to CAR T cells. What are CAR T cells? They are T cells which are taken from the patient. Those T cells are then sent to a lab where they are transfected with a gene that incorporates DNA that allows the cell to make what's called a chimeric antigen receptor, or a CAR, which in this case is specific against CD19. Process which takes between 3 and 6 weeks, and then those CAR T cells go on to kill their target cell, which in the case of a leukemia patient is the CD19 protein. And so the type of CAR T cell that is used in Australia, Tisangalucil, is been looked at in patients with relapsed refractory ALL in a study called the Eliana study. A relatively small study, 75 patients. It was a younger cohort of patients, so only up to age 23. Patients had at least 3 prior therapies, up to 8, and at least 60% of patients had a previous transplant. In this study, it took 45 days to have the T cells transfected and then re-infused into the patient. But you can see that for these patients who were very high risk, they had quite a high CR rate, 80%. In patients who achieved a complete remission, all of those had an MRD negative response, so really an excellent response. But again, the event-free and overall survival, while it's much better than might historically have been the case for these patients, remains relatively low. So event-free survival at 12 months was 50%. And there were unique toxicities associated with CAR T cells, including cytokine release syndrome, which can be an issue in blinatumomab, and neurotoxicity as well, which can also be an issue in blinatumomab therapy. Because this was a relatively young cohort that was designed to include patients up to the age of 25, that is the age limit for CAR T cell therapy for relapsed refractory ALL in Australia. So lastly, I wanted to come to the importance of clinical trials and the reason why we should have ALL patients, particularly adults. It's a relatively rare disease. We really don't treat it. Our outcomes are not as good as for patients who are younger. So we really need patients enrolled on clinical trials so that we can improve their outcome. And if there is a clinical trial available at your site, then I would strongly encourage you to consider participating if you're eligible. And the reason why clinical trials are really so important is exactly this graph here. So this is a graph of survival for children with ALL. who are enrolled on the Children's Oncology Group clinical trials. And you can see that from 1968 to 2009, there really has been a dramatic improvement in outcome for patients enrolled, typically children enrolled on COG clinical trials. And the reason why this is remarkable is that over that time frame, there really had been very few, if any, new introduced chemotherapy agents, but they were being used in different doses, in different schedules, and over different time frames to try and improve outcome. And so really just using the same type of drugs that have been available for the last 20 or 30 or 40 years, there has been a dramatic improvement in outcome for children treated on ALL clinical trials. And those results can only be achieved by having large groups of patients enrolled on clinical trials. And you can see here the children's study groups have the sorts of numbers that adults could only really dream of. This is a much, much more common disease in children than it is in adults. You see some of these trials had over 8,000 individuals enrolled, but sometimes that's the sort of numbers that are required to show even a minor difference in outcome. So it's really critical that we have trials so that we can improve everyone's outcome over the longer term. So that's really all I had to say. I think I've probably gone a little bit over time and I apologize about that. But in summary, ALL is a bone marrow cancer and it involves immature lymphocytes that are called lymphoblasts. Treatment in adults is dependent upon age. The older you are, the less intensive the therapy is that you can be offered. And Philadelphia positive status, that means we can add a tyrosine kinase inhibitor to try and improve outcome. Younger age means more intensive therapy, better overall outcomes. The options on relapse are expanding, but long-term experience is lacking. And again, we really, really don't want patients to relapse. We want to cure them in their first remission, if at all possible. Clinical trials clearly improve outcomes, and every adult should be encouraged to participate if a suitable trial is available. And with that, I'll open the forum up to questions if there's time.
Matt, we do have a couple of really quick questions. We have one from a 72-year-old gentleman living with ALL who has experienced several relapses and had several lines or cycles of Blinatumomab and has experienced cognitive, mood and balance side effects. Do you have any suggestions to help minimise or mitigate these side effects?
Over time, a lot of the treatments that we use in ALL, because they are CNS directed, patients can experience some neurotoxicity from those treatments. Typically, they are short-term side effects that often almost fully resolve. Blinatumomab is associated with or can be associated with neurotoxicity at the time of the infusion, and again there are protocols available to try and minimize those side effects. In the longer term, I'm not sure that I'm aware of literature suggesting prolonged neurotoxicity from Blinatumomab. But I'm sure the treating team have some ideas. They may have done an MRI scan or other lumbar punctures looking to see if there's something that can be addressed. But usually time does resolve much of the neurotoxicities associated with the treatments that we use in ALL.
Thanks for that, Matt. Just one last question, and around obviously COVID being such a topical issue at the moment. What are the 3 key messages that you are giving to your ALL patients and their families or close contacts around the COVID vaccination?
So at the moment, we're encouraging everybody to proceed with their COVID vaccination. We're encouraging family members and patients to proceed. The thing that the patients need to understand is that while they're getting treatment for a blood cancer, their response to the COVID vaccine may be limited. Certainly, antibody responses appear to be lower in patients who are treated for a blood cancer to less efficacy overall. But clearly there are some patients getting treated for a blood cancer who do respond to the COVID vaccine. So assuming that you don't have any contraindications to proceeding to the type of vaccine that's offered to you, given your age group, we are still encouraging everybody to proceed with their COVID vaccines, understanding, of course, that patients who are getting treated for a blood cancer may have, and it's not clear whether that equates to but it's not dangerous.
Great. Thank you for that messaging. I think it's an important and topical subject matter, and glad you were able to make some comments about that. Thank you. We are going to move on to our third speaker for this morning. That's Professor Deborah White. Professor White is the Director of the Cancer Program and Deputy Precision Medicine Theme Leader at the South Australian Health and Medical Research Institute, or SHAMRI, in Adelaide. She is the NHMRC Research Fellow, a Beat Cancer Principal Research Fellow, and Senior Principal Research Fellow with SHAMRI. She is a Professor in Health and Medical Sciences and in the Faculty of Sciences at the University of Adelaide. Professor White's research focus is genomics and rationally targeted therapies in acute lymphoblastic leukemia. And she has presented more than 170 papers at scientific meetings and authored more than 120 scientific publications. Professor White is the national flagship lead for the ALL stream of Australian Genomics and South Australia scientific lead for Zero Children's Cancer. She is an active member of the National Health and Medical Research Council, being on a number of working parties. Professor White has received a number of awards: the Australian Society for Medical Research Leading Light 2014, the University of Adelaide's James McQuay Medal 2016, the prestigious NHMRC Research Excellence Award in 2019, and the Beat Cancer Women in Leadership Award 2020. Thank you, Deb. I will hand over to you.
Thanks, Linda, and thanks to the Leukaemia Foundation for organising this and to the sponsors. So I have been tasked with talking about precision medicine in acute lymphoblastic leukemia. For us, this is, as you have just heard, pretty much a day-to-day job. So my group, my laboratory here is focused primarily on genomics, but also on some other areas that I'll talk to at the end of this talk. And looking at the genomics of ALL and really trying to pair that with therapies that we can use. So there's several layers of this that I think, or hopefully by the end of the talk, you will understand. I really want to start by making a key point, I think, and it's a really key point for patients to understand. It's also a call out and a thank you. Things don't change. So you saw the curves that Matt showed you where we have seen a significant increase in childhood survival, and largely because children participate in clinical trials. Research doesn't survive without patients, and things don't change without patients becoming involved in research. They also don't change without funding. So again, that's a call out to Leukaemia Foundation, who have in fact supported some of the work we've done. But really, patient clinical engagement are critical to make a change in any disease, but particularly in the blood cancer or in ALL, like I'll talk about today. So if I can actually find my mouse, there we go. So what is precision medicine? So I've gone back to what the National Cancer Institute, probably one of the largest bodies in the world to give us definitions, describes precision medicine as. You will note as I go through this, I also use a term that's called personalised medicine. They're kind of the same but different, and I'll point out the differences as we move through. We work in both precision and personalised medicine. They are interchanged, but strictly speaking, not interchangeable terms. So what is precision medicine? It's really, according at least to the NCI, it's about discovering unique therapies that treat an individual's cancer based on the specific genetic abnormalities of that person's tumour. I don't necessarily think that this is complete now, but it's certainly, if we were to pare that back and think about it, it's about hitting the target. It's about fully understanding the target that we're dealing with. And we'll talk as I go through this seminar with how do we actually do this. I think it's not always about drug discovery. It is about repurposing drugs. It's also about adding some of these repurposed drugs to the chemotherapy regimen, whether that be modified or unmodified. And we're seeing multiple levels of change throughout the regimens, as Matt highlighted. We also need to think, and so the precision medicine definition that came from the NCI really came into being at the time of the Human Genome Project, where the first human genomes were sequenced, remembering that that took somewhere between 2 and 3 years, if not longer. A normal ALL gene, normal's not quite the correct word, a standard genotyping or transcriptomic sequencing that we do of an ALL genotype would be on a sequencer now for at the most 6 hours. It will take us a little bit more time to understand that genome, but that's moving across the genome 60 to 80 million times in order to get a correct read on the genome. So I'll talk about that a little bit later. But we now move from doing what is still incredibly complex laboratory work in doing genotyping to now starting to look at other factors. So what I'm really going to do is take a start at the outside, move in, and then start to move back out again and explain to you how we're trying to, if you like, fit the maze together. One thing that I think everyone would agree on is that precision medicine is definitely about hitting the target. And the better we can hit that target, the better outcome for patients. What we don't want to do is miss the target completely. So sometimes this happens when, and particularly happened in the early days of solid tumour precision medicine, where we saw in occasional patients responses that were thought to actually then could be rolled out to patients across the board. So for example, in lung cancer, incident responses saw a rollout of drugs, but in fact what wasn't known was the target they were looking for. And ultimately most of those drugs failed, which is unfortunate because had we known the target, and in fact now some of them are coming back in. So it's about target recognition and being able to design or use drugs that will hit a target. What we often also see is, and this is unavoidable in some instances, but largely we see that we can hit the target, but we'll hit other things as well. I'll talk about it. Matt also spoke about tyrosine kinase inhibitors, and that is certainly the case with these drugs. Excuse me. So Matt took you through the diagnosis of ALL. You saw the picture of the ALL blast. They are big, they are nasty, and they do look quite different to normal cells. So if we want to characterise, so to do precision medicine, we need to actually understand the target. We need to be able to completely characterise the disease we're dealing with. So the first step there, as Matt mentioned, is to look at the cell surface. We can look at what's sitting on the cell surface, and we know that most ALLs are classified as B-cell ALL, and about a quarter, it varies across the age groups, would be T-cell ALLs. So that's our first step. That's our first handle. Have we got B-cell ALL or have we got T-cell ALL? And I'm simplifying this, obviously. If we then want to understand more, we need to go inside the cell. So characterising B and T cells is largely done on the outside of the cell surface. If we want to understand what's going on inside the cell, we need to literally pull the cell apart. And our primary focus there is the nucleus, because that's where most of our genomic material sits within our chromosomes. So we can do chromosomal analysis, and I'll show you a little bit of that. And that gives us an indication, and actually a really good indication of many subtypes of ALL. But if we want to go even deeper, we need to deconvolute those chromosomes. So what we need to do, really, if you want to think of it in simple terms, is we need to unravel them. When we unravel them, we reveal the genomic material, the DNA and the RNA, that is our genetic code, and we each have a unique genetic footprint, if you like. So basically, from the very beginning, we can decide whether the cell is T or B cell, and we can start to look at what the chromosome changes are. If we go back to thinking about precision medicine, so keeping this in mind, if we're talking about standard treatment, so here I'm referring to routine chemotherapy, we previously can group patients as T cells or B cells and give them therapy associated with that. But you will see here, and you will see as this talk progresses, that not all B or T cell ALLs are created equal. And in a rather strange analogy, some people have purple legs and others have red and green. However, it goes to show that there are different subgroups, and that if we use a standard therapy, for some we will see an effect. For another group, we'll see no effect, and even worse, for the final group, we'll see adverse effects. So understanding this, recognising that people are different, will make a difference and does make a difference in the majority of cancers, and of course ALL is no exception. So personalised treatment, here we're not just talking about hitting a target for a group of people, but we're also talking about understanding the target at the individual patient level. This does involve genomic analysis. But what you can see very simply is that we can genotype or do deep sequencing on these patients. We can then group them into those with, in this example, green limbs versus multicoloured limbs versus purple limbs. And ultimately what we want to do here is give them the therapy that matches, in this case, their limb type. So that group of patients gets the right therapy for that disease. And that may be repurposed, or it may in fact be, as is shown here, a pill with someone's genomic code on it. We're not there yet. We're a long way off of that. But we certainly do have many more tools in our toolbox and many more treatments that we can use. So Matt showed you this diagram. I'll go through it very quickly. I use it primarily because it is the best example of a targeted therapy. And the reason that it's the best example, so this is the Philadelphia chromosome. It's a chromosome translocation between chromosome 9 and 22. It is the best. We first discovered this in about 1950. It was well described by the 1960s. The Philadelphia chromosome is named such because it was identified in Philadelphia, but primarily it is important because this single gene translocation or chromosomal translocation is necessary and sufficient to cause a disease. So it causes both chronic myeloid leukemia and Ph positive ALL. The translocation brings together two genes, the BCR gene and the ABL gene, and bringing them together creates a protein which is known as a tyrosine kinase. But a simple analogy is if you put a tyrosine kinase into a cell, it's like giving someone an accelerator without the brake. So these cells divide and divide and divide. Several years ago, very clever groups of people managed to actually do a crystal structure of a BCR-ABL protein. And the key area is in here, basically, that drives the cell. So what the group at Novartis, or at that stage Ciba-Geigy did was design, very cleverly, a drug that fitted completely in there. The rest, as we say, is history. It was the first ever personalised medicine and the first ever targeted therapy for a genomic abnormality, albeit a gross genomic abnormality. In other words, it's a chromosome translocation. But this is really the hallmark of personalised therapy. And it really tells us that understanding the disease leads to successful treatment. There is no greater success in a very short period of time based on the use of really a single therapy or a single class of therapy. So this is looking at chronic myeloid leukemia, a more indolent disease, but still universally fatal without efficacious treatment within 5 years. what we can see is a 52% increase in survival in 20 years with the introduction of more rigorous therapy, but also with the introduction of targeted therapies and increasingly good targeted therapies in this disease. It's probably fair to say, I've put 2020 there, it's probably 2019, that anyone who was diagnosed now or is diagnosed now with chronic myeloid leukemia would be expected to live a near normal life expectancy. This is as a result of understanding the disease. This is a result of understanding the biology, the genomics, and being able to design or repurpose a drug directly for that. So let's step back into the realms of ALL now. So this is what we knew about ALL at the turn of the century. We knew that there were T cell subsets as shown there in red and in green B cell subsets. Some of these conferred really good outcomes, some less good, but we knew from this stage, from the turn of the century, so 21 years ago, we knew that about a quarter to a third probably of patients we didn't know very much about. In fact, we knew nothing. So cytogenetics could not go deep enough for us to understand the disease. But what we did know about this group of patients is they did really badly. So that group of patients were the patients that relapsed, the patients that at the beginning of their disease looked the same as every other patient, so we couldn't define their disease, but we also had no tools in the toolkit to actually understand it. So clearly looking and understanding this group of patients, and we did some work on growing these cells, etc. And again, as you can imagine where this talk is going, this group of patients have really been identified, and the work of the Worldwide Genome Project has helped us understand this disease a lot better. So if we really, and we began this work focusing on that group of patients, doing genome sequencing, and genomics, as I'm sure most of you know, is really just a whole heap of A's and G's and C's and T's, and people sitting down and reading them, or in fact machines that do that these days. But in a clinical sense, the importance of this is that by reading that genome, we're able to identify things or proteins that drive the disease. So we call them fusion transcripts. It's where two genes, a bit like BCR-ABL, two genes that don't normally come together, and when they do, they cause a cancer. And I'll show you a little bit more about that in a moment. But in those cases that are cytogenetically cryptic. So what I mean by that is that we don't see big chromosome changes like we saw with BCR-ABL. We see the genes move, and you can't pick that up with cytogenetics. You can't pick it up with a light microscope. We actually need to go much deeper, and that's where we sequence to pick up these gene fusions that we now know are critical drivers of many aspects of this disease. So this looks kind of manageable. If we look at the pie chart there, we've got probably about 13, 14 different subgroups of ALL, a little bit more complicated than we'd like, but we embarked on genome sequencing, as did a lot of other groups around the world that we collaborate with. We've now sequenced, actually it's very close to 800 samples of diagnostic ALL. This is a subgroup of them. But your take-home message from this, I'm sure in the first instance, will be, well, you've done a great job of complicating things, because we have. We've now down to the stage where that group of 25 to 30% of patients is probably down to less than 10% that we can't identify what's driving the disease. But we have uncovered many different subtypes. So that's really important, because that's not always a bad news story. What we have discovered is some subtypes where outcomes are really quite good. And we're gathering the information globally to see whether those patients could in fact have dose de-escalation, or whether in fact there are targeted therapies that can be used for both high risk and low risk diseases. So our kind of simple cytogenetic picture has suddenly become really complex, and you know, I hate to tell you, but this is only one particular age group, so the story is actually more complicated and somewhat more daunting. But we have tools that will allow us to deconvolute this data, and I employ as many bioinformaticians now as I do scientists in order to actually handle this level of data that we generate. But we now know what causes and what drives a large number of the ALL subtypes. So for most patients now, and in fact, you know, we're pushing globally that for all patients diagnosed with ALL, they are actually sequenced so that we can generate a subtype, so that we can identify the best therapeutic options for these patients. So as I said, it looks very confusing. I think the things, and I've tried to take the complexity out of it here, but just show you that for around 90% of patients, what we can now do is look at the risk stratification using deep sequencing. Now, I think what I forgot to say at the beginning is a lot of ALL's patients, when they're diagnosed, look exactly the same as the person sitting in the chair next to them, but their disease would be incredibly different, or is likely to be. So these subtypes can't be picked by routine diagnostics, whether that be the bone marrow, a variety of other biopsies, or whether it in fact be by cytogenetics. So we do need to go deeper to pick these up. But we can change risk stratification using, by gathering this better understanding. We can look at an ongoing investigation of different therapeutic options, and that may be a triage to something like Blinatumomab, as Matt was talking about. Or it could be by repurposing or developing new drugs, and we're involved in all of these areas. If we wanted to go and look at this is a very high risk subgroup, and I don't have time to go into much of this, apart from to say that it's very much like pH positive ALL or Philadelphia positive ALL. These patients don't have BCR-ABL. They do have lesions that look a little bit the same, and they do overall have poor outcomes. So this is looking at one small subset, and really the take-home messages from this slide are that there are many different lesions or subtypes of ALL, as I've shown you. But what's really important is that there are many different possible therapies that can be used, and a large number of these are already, in fact, all of these are in the clinic, not for ALL specifically, but for other diseases. So this is where this repurposing concept comes in. Yes, it's complicated, but as I said, with several years now where we've been doing this in the clinic, we have the tools, one, to integrate this much more into the clinical picture, and two, we have the ability to test in the lab, as I'll show you, these drugs against patient cells to see whether they're likely to work or not. So by understanding the disease, we can specifically target it. Really just looking quickly at how we develop precision medicine strategies. If we look at cell lines, so the first stage is cell lines, where we actually take the new fusions that we identify by sequencing, we put them into cells and we ask a question about how they respond. Very simply, if they're not leukemic, they stay down on the bottom. If they are, they do this, they grow. So we know then we're dealing with something that can cause leukemia. And the good thing about this system is what it then means is we can test our drugs against these cell lines. These are developed in the lab, they're not actually out of a patient. Our second strategy, and really what we have to do to get into preclinical development, so we have to do mouse models before we can take new drugs to market or into a patient, is that we take cells from a patient and we put them into a mouse. You can't do these, we don't like using mice, but you can't do these tests in patients. And it allows us to capture the leukemia of the individual patients, and therefore it really is personalised medicine. We can then look at the effect of drugs by either looking at survival, so these mice obviously die earlier. These mice out at the later stages here, I'm not sure we can see my arrows, obviously we see a survival advantage in giving drugs. We can also use bioluminescent imaging where we don't actually have to kill the animals early and look at, so what you're looking for here is this is leukemia, bright blue and green. Here we can see that the drugs have been efficacious. So this is our sort of approach to looking at genetic lesions. So have we solved the problem? I've told you that the genome is complex and that the changes are complex, but we know that ALL exists in the body. The body's a complex organism without doubt. And there are other things like the immune system and drug metabolism that will have an effect. And we do know that even within subgroups, and this data is now accumulating, not all patients respond equally well. So we need to really take a step out now. So we've gone deep into the cells, take a step out and look at the systemic picture. And our focus here, and this is work supported by the Leukaemia Foundation, is looking at the microbiome and the immune effects. And that's largely because we know that the microbiome has been shown in some of the solid tumours to actually have a marked effect on the efficacy of chemotherapy. So the systemic approach looked a little bit like this. Obviously, a patient DNA and sequencing will remain important for subtype development. We know that patients are going to get anti-cancer therapy, and we know that that therapy will affect the gut, without a doubt. And I'm sure many of you have been through chemo will know that. But we need to ask some questions about what the effect of cancer therapy will be on the gut. And the importance of the gut is it is incredibly linked to your immune system, and your immune system does alter the way we respond to drugs, and the drugs alter the immune system. So we're working in a delicately balanced environment, and really to ask some questions about how the gut microbiota affects response to therapy, because we know that there are long-term effects. So we do this very quickly using another mouse experiment, and to cut what is a very long story short, we have a special little mouse that not only can be transplanted with human leukemia, so we can understand how the leukemia will respond, we can also transplant these patients, these mice, with human fecal material to look at the gut effect. So in this mouse, we can manipulate the immune system and the leukemia to test therapies to see whether we can get an efficient and effective change and improve responses. So we've shown so far we can grow the leukemia cells, and we can recapitulate the gut into these mice, and we can show immune changes. So this is really going to be very game-changing in looking at personalised medicine for ALL patients. So I showed you this diagram earlier, and really just to come back to it, we talked about genomic-based therapy. The probably next kid on the block with regard to this may be specific bacterial therapy that in order to enhance our immune system via the gut, or could be through fecal microbiota transfer. We know in other diseases there is now really good evidence that transferring fecal material from either a normal or from a good responding patient can actually improve responses for patients. So I think I've made it hopefully understandable throughout this that the personalised ALL or personalised medicine program or precision medicine program is clearly a direction that we and others are going, and you heard a bit about this from Matt as well. It does take a small village. It takes, importantly, engagement with patients and clinicians. It takes a heck of a lot of funding. The sequencing doesn't come cheap. We have a lot of support from philanthropy and infrastructure, but also from funding organisations such as NHMRC, Cancer Australia and Leukaemia Foundation. We see a coalition of many willing people, and largely we bring together now, and very strongly, bioinformaticians, biomedical researchers, clinicians, and our patient material, and we meet on a weekly or fortnightly basis to discuss each individual patient and what the outcomes are. This isn't Medicare funded at this point, although hopefully at some stage we can do that. So all I want to do now is close and thank my ALL team. This is, as I said, it is a small village, but a really hard-working one. And I think we've made significant inroads into understanding this disease over the last few years. So thank you.
Thank you, Deb, so much. That was extremely informative. I know I got a lot out of it, and we do have some questions coming into the live feed. So I will direct the first question to you. This is a question about investigations, and do researchers investigate about a leukemia patient's environment or their lifestyle that might cause them to get a blood cancer? And is a database kept on such information in order to pinpoint why people develop leukemia?
That's quite a tricky question. I personally don't work in the prevention or early stage space, although do have a little bit of interest, particularly in, this is more in the children than in the adults, but we do know that some kids are born with a predisposition to leukemia. We don't, Leukaemia Foundation may be able to answer this, we don't keep a register of the lifestyle that occurs in a patient prior to them developing leukemia. We do monitor what patients, to some extent, what happens post leukemia. So there is clinical information that is gathered within databases that is accessible in a de-identified fashion. But as far as a simple answer to the question, and I don't know whether there's anyone else on the line, Matt or anyone could talk about this, but largely preventative research at the moment, as far as I'm aware, is not front and centre in ALL, and I think largely that is probably because we're still understanding the disease, and it may be something that comes to the fore later on.
Thank you very much. Matt, did you want to add anything to that question?
Look, only to say that some of the predisposing factors that might be at play in the development of ALL are better recognised, albeit very uncommon in children, and much less well so in adults. I think it's important to understand that ALL is a much less common entity.
Thank you very much. Matt, I also have another question for you.
Right, okay. We do collect some demographic data on the basis of the National Blood Cancer Registry, but it's very difficult, and this hasn't really been identified in adults, that there are particular predisposing factors, environmental factors or otherwise, apart from very obvious ones, such as exposure to radiation, things like that, that might increase somebody's risk of getting does have a relationship with treatment toxicity and outcomes, particularly using more intensive protocols. But apart from that, and basic things like gender, there's not really much evidence for other environmental factors at play.
Thank you, Matt. I think it's also good to remember that they are questions to ask your treating haematologist as well, if you still have concerns around that. Another question
Absolutely.
Another question we have is there a national body that oversees all of the ALL clinical trials in Australia?
The Australasian Leukemia and Lymphoma Group is the main haematology clinical trials network in Australia and New Zealand, and the bulk of the investigator-initiated studies in adults are sponsored through the ALLG. It's different in children. There are two main clinical trial groups active in Australia, one which is based in Europe and one which is based in the US. But for adults, the overseeing body, if you like, that sponsors investigator-initiated studies in Australia is the ALLG.
Thank you, Matt. And we'll just have time for one more question. What are the long-term effects of being on TKIs, and are there non-target issues?
Sort of off-target issues in being on TKIs. Is that the other side effects from being on TKIs?
Yeah, the long-term side effects of being on TKIs.
So probably the bulk of the experience has been with imatinib, and there are patients who have been on imatinib now for many years. Imatinib has been standard of care in CML, as Deb alluded to. really from the late 90s through early 2000s. So some of those patients have been on imatinib for potentially up to 20 years. So that's the bulk of the experience. In the newer generation TKIs, that there is less experience, but the bulk of the abnormalities appear to be, the bulk of the toxicities appear to be early, when patients are first being exposed to their TKI, and they do vary according to which TKI people are on. In the longer term, most people seem to tolerate TKIs reasonably well. There may be some impacts on fertility depending upon age group and what your fertility state was like at the beginning. But in general, there aren't specific side effects that seem to be related to TKIs, but the experience with the second generation TKIs is fairly limited in the longer term.
Thanks, Matt. We don't have any more questions on the live question and answer feed, so I'll put you back onto Linda to close the session for the day.
Thank you, Jane, and to Professor White and Dr. Greenwood. I think what we've certainly heard today really demonstrates the important link, and I think Professor White really highlighted this, the important link between the person's lived experience, the clinical management, as well as the research, and that all needs to come together in order to move forward in innovations and support for people living with ALL. We really can't have one without the other. So that brings this session to an end. Again, I'd really like to thank everyone for your time today, in particular our guest speakers, Mark Reed, Dr. Matthew Greenwood and Professor Deborah White, for your incredibly valuable time and contribution. If you have any outstanding questions or comments from today, please don't hesitate to reach out to us on the number on the screen. So thank you once again, and have a great day.